Hey everyone, welcome to Taking the Pulse, a healthcare and life sciences podcast. I am Heather Hoops Matthews with NP Strategy, here in the studio today with Matthew Roberts, Nexon Pruitt Healthcare Attorney. Matthew, good to be with you.
Good to see you.
And welcome Jordon Ritchie. He is the CEO of Aimedica, a EHR optimization company, which for lay people like me, that's an electronic healthcare record. Aimedica team has been working towards a mission of simplifying healthcare by delivering the right technology to the right doctor at the right time. Jordon, that sounds like a tall task. Thank you for joining us.
Pleasure to be here. Thank you.
If we can start with a little bit of background, if you could talk about just the transition from paper medical records to this electronic system where we have EHR records. What caused it? How far along are we? Where do we have to go?
Of course. So the transition from paper to electronic health record systems came with some acceleration trauma. As many will recall, the government pushed and incentivized the adoption of electronic health record systems quite heavily, which had an interesting effect, right? Because we were taking these systems that were, taking filing rooms, this really complicated, color coordinated system for doctors to keep track of these paper charts. Fax machines played an integral role. The infrastructure was all different, and very, very quickly went towards this all electronic solution that because of the government's pressure to drive adoption. I mean, huge incentives, right? These health systems were given some pretty big help in paying for and adopting these electronic health record systems. And companies like Epic and Cerner and others really cleaned up. But it was interesting because what happened is it created these EHR systems solved a problem, right? They were just a database essentially that was formed to take in all these paper records. But and the promise, the selling points were high, right? This is going to automate physician workflows, and it's going to make it easier to access data. It's going to be easier to share that data, right? And it's going to drive better healthcare outcomes, better physician experiences, better overall health across patient populations. And what we failed to do in that process was put in safeguards that ensured key technology standards that allow interoperability. And so things like, we're seeing lots of these technical standards come into play now that make it easy to share data. But at the beginning, that didn't exist. So you ended up siloing this data almost as badly as it was in paper format, right? Except now you added an extra step. Before you faxed a paper record to the next doctor's office, you had to print it first, right? And it really is that archaic still in some places. We've taken some big steps forward, but because there was such I think of it like acceleration trauma. We accelerated so quickly. These EHRs didn't quite achieve product market fit, maybe product solution fit, but they didn't really have that opportunity to iterate and undergo the rigor of achieving what does the customer, the user, really want. And what's ended up happening is we've created a solution that, yes, digitizes paper records, right? That we're able to store patient records inside electronic format, but ultimately doesn't serve all the users very effectively, right? We see a lot of physician burnout and a lot of pain that's come with the adoption of electronic health records, and unfortunately not as much of the promise that we originally had hoped.
That's certainly the case. I mean, you ask physicians, particularly physicians who didn't grow up with this, it was a massive amount of time spent learning how to use it, and it adds time to the physician's day. It doesn't take time away. So there's still a lot to be done, and that's where hopefully you guys come in. Let's talk about Aimedica and the specific role it will play in the ongoing evolution of and improvement, hopefully, of EHR.
Of course. So the picture that I wanted to really paint there was that these EHRs, while they're these big systems, they exist and they're doing something, but they have a lot of optimization needs. And specifically, they have optimization needs for physicians and for patients, right? EHRs really, at the end of the day, have become glorified billing systems. The only real true value or benefit that was pulled out of digitizing those paper records is it got easier to involve insurance in making claims and automating that billing process, which is the part that patients and doctors actually care the least about, right? The part that Aimedica is trying to enhance now is on top of that excellent billing system that's been put in place is clinician workflows. So all of those data points that go into the EHR, hundreds of thousands of them, physicians are liable for every single data point that goes into the EHR. But the amount of time that it takes for them to go and pull that data out of the EHR as they're making clinical decisions for patients is this long, laborious hunt and peck process inside, ancient looking EHR user interfaces that physicians don't have time for this, right? I mean, we're talking about physicians who are working 12 to 36-hour shifts, depending on their call schedules, who see tens to, maybe close to, hundreds of patients a week. It's unrealistic for them to be able to put that kind of time and energy into a software solution to get the data out that they need to take care of their patients. And so what ends up happening is physicians often have to make their best judgment under a time crunch based on patients they've seen in the past. And they do an excellent job. Physicians have excellent training, right? They're very, 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 very efficient, very good at what they do. They undergo a lot of rigor, but there's so much we can do in automating and optimizing clinician workflows within the EHR to pull that data out of the EHR for them and present it in the right format at the right time when they're treating their patients. And that's where Aimedica sits. Our job is to understand what data does the physician want to see, how do they want to see it, and what math can we do on it automatically without them having to think and present it to them. Because the amount of data and knowledge that we're generating is growing exponentially. And then the idea that physicians are going to be responsible for that and know it, and without technological help is crazy.
Right.
How does your company's use of risk scores play into this when we're talking about, clinical data?
Great question. So the term here is evidence-based medicine. It's a buzzword. It's been heard in lots of places. But really what evidence-based medicine means is, we're going to take, this is translating work that's done in research into clinical practice. And it turns out that gap from research to practice is about 17 years. Which is nuts. It's a crazy amount of time, right? But the output of a lot of this research is a calculator or a risk score, right? We're talking about where essentially we say, okay, based on a whole bunch of other patients that we've seen before, we know that at certain thresholds for certain inputs, age, height, weight, creatinine value, it might be so your lab values, your vitals, your medications, problems you might have on your problem list. These are all inputs, right? And so what we can say is for a particular set of inputs, we can create a calculator that at certain thresholds based on a mathematical function, we can predict certain outcomes like, maybe it's in-hospital mortality for a particular group of patients based on a disease, or maybe it's the amount of fluids that they need to avoid, or their risk of major bleeding if they have atrial fibrillation, or any other number of things. There's hundreds of these calculators. But the problem is that the data, the inputs for those calculators, they live in disparate places in the EHR. And so what we're able to do is we're able to integrate with those EHRs and automatically pull those pieces of data, put them into the calculators, and run the results or run the calculators and get the results based on these complicated mathematical functions that researchers have discovered and present them to clinicians without the clinicians having to know the literature exists, look it up, understand the calculator, find the data, plug it in, get the result. We can automate that all for them immediately. And again, hundreds of these calculators, we can look at the patient before we run our tool and say, hey, this patient has disease X, Y, or Z. And we know that those diseases are, there are specific calculators that map to those diseases. We can just automatically run the calculators with whatever data is available and then turn it over to the physician. The physician now can go make the decisions whether they want to use the calculator and what do they want to do with the result. And it gives them, again, the right information, right time in the right part of the workflow. Right?
So Jordon, this is how are the physicians, hospitals, and payers receiving this technology that that you've developed in the use of automated dynamic risk scores and data mapping?
It's a great question. There's a very, very intricate balance to achieve here, right? Because what we hear very frequently is this idea that physicians say things like, "Well, I've always practiced evidence-based medicine," and yes, that's true, right? We're not replacing what doctors have already done. We're trying to automate it, take away the menial labor that physicians have to do to make them more efficient, more effective, to operate at the top of their license, right? And so what ends up happening is we pull as much and present as exact the data that they want, but we never take away the clinician's judgment. So we never push a score or order a medication or anything like that. All of that lives with the doctor. The doctor still is making the decisions, and this is the fundamental theorem of biomedical informatics, by the way, which is this idea that an algorithm and a doctor together are greater than the sum of their parts, right?
Right.
The idea that computers and AI and machine learning is going to replace medicine or replace doctors is absurd. That's crazy. We're not even close to anything like that. And I don't expect we ever will be. I think we will always need humans to direct algorithms to look deeply at the right problems to make judgments about how to treat patients.
Is there? Yeah, it did. But is there a chance that this information can be used? Like, let's example, you mentioned insurance companies. Could they use this information in a way to call into question the clinical decision making made by a physician to challenge whether something was covered or not?
They already do.
Yeah.
The reality is insurance companies use copious risk scores, most of them incidentally created by the insurance companies, which if you take a minute and think about, should really scare you.
Yeah.
Because insurance companies have no business practicing medicine, but interestingly, EHRs in their current format have kind of become this, it's a mechanism whereby the system can abuse doctors in a lot of ways. Because you start talking about prior authorizations, you start talking about the copious amounts of documentation that are being heaped on doctors that they have to fill out. That some of the screenings they have to do for every patient, regardless of what kind of patient it is. It's absurd what we're asking. I mean, we can't keep asking doctors to do more. And right now, EHRs are this behemoth kind of amorphous mass of technology that doesn't really do anything really well except for billing, that is being used by insurance companies and even health organizations to an extent to bully doctors into essentially burning out. And we're seeing it brutally too. Doctors
it's clearly that the EHR results of the EHR are clearly not affecting the patient in a positive way. We don't see those results, how it's currently being used.
I think that if you talk to anybody, they will probably say they feel that EHRs have fallen short of their original promise. That doesn't mean that they can't deliver on that promise in the future. And we're taking promising steps towards an environment that will. Things like the Office of the National Coordinators of Health Information Technologies 21st Century Cures Act that recently came out was really positive, right? There's the anti-information blocking rules. There's some really important steps that are being taken legislatively to open up EHRs so that, now as of October this last year, patients now have the right to request their medical records from any EHR, and they, by law, should not pay for it, should receive it immediately in the format that they asked for it, which is a huge step forward, by the way, from what it was. I don't know if you've ever tried to get your records out of EHR before, but it's like pulling teeth out of anesthesia.
Very difficult. Very difficult.
What about just people's openness to what you're talking about, automated, dynamic risk scores? Are physicians and hospitals and payers open to that at this point?
It's a great question. There's a movement right now that's been really exciting to witness. This idea of automating evidence-based risk scores, clinical decision support, putting evidence-based medicine at doctors' fingertips for their disposal and use in treating patients, it's gaining traction. It's getting exciting, and especially for doctors. Doctors are beginning to expect this more and more. We're getting and this is all too natural too, because you think about the doctors older doctors who are less technology savvy are starting to retire and are starting to move out of the system, and you've got younger doctors who grew up with social media applications and iPhones and technology, and they're expecting that, they see the rest of the world and they know how technology works. They expect it in medicine too, right? So more and more we're seeing a shift towards this expectation that the healthcare technology sector is going to finally step up and start functioning at as high a level as, say, online banking or online commerce or any other number of large online businesses that function at a high level. So I think there's a trend. There's obviously some if you're looking at the adoption curve here, I'd put healthcare on the laggard side of the technology adoption curve, right? I think is an understatement, but we're moving the right direction.
Can you talk about some of the current partnerships that you have with the product and some of the results of those partnerships so far?
Sure. We have a great relationship with St. Luke's Health System in Idaho. They have been outstanding. We have they're our development partner, and they've worked with us initially here to create our first version of the app, and we're currently deployed there. We've gone. In fact, it was kind of a big moment just recently. We finished up a project with them here, but we've run thousands of calculations now, and for their doctors, working with different patients across a whole bunch of specialties, from NICU to cardiovascular to internal medicine. There's a whole bunch of and surgery, peri-op. We've got a whole bunch of different sets of calculators in these different areas and across these different specialties, and it's been really, really exciting to see. The doctors at St. Luke's have been really helpful and really excited to see something come into the EHR that's for them, which is unfortunately a rarity. With tight budgets and EHRs are already expensive, and COVID exacerbated things, and a lot of health systems in the country are saying things like, there's just no money in the budget right now. We're strapped for cash, and things are really tight and lean. To have something that is for the physicians that not only makes their life easier and better and improves patient care, but also bodes well for the hospital. If you think about a health system that can see and track in our system how well their doctors are applying the standards of care, evidence-based medicine, these are validated models. The extent to which they can drive it, you're going to get better outcomes for your patients, and better outcomes for patients always, always, always translate to better financial outcomes, period.
Right.
You mentioned St. Luke's. Is it just hospital systems who would buy your platform?
It's a great question. Right now, we're marketing mainly to health systems who have EHRs that are FHIR compatible. We integrate. FHIR is an acronym. It stands for the Fast Healthcare Interoperability Resource. It's the industry standard for interoperability with health data. And so we're developing into those standards. We can integrate with any EHR that supports those standards. And so we integrate through the EHR and we market to the health system. That said, we've built our product as a service, and it's available for anybody that has value or would find value for implementing these systems. So anybody that has that data, the inputs, the lab values and vitals and problems and medications, et cetera, that are looking to understand a population or a patient's health in regard or in relation to these calculators, we could certainly work together.
How is Aimedica's platform used in clinical research? Because I know that's something else that it could benefit.
It's a great question. Yeah, we're really a research application tool, right? We take research and we apply it. We put it into the field. We give it to the doctor so they can use it. The research that we're doing that's really exciting, though, is if you think about evidence-based medicine, as we've described it, these calculators, resource predominantly right now lives outside of the EHR. So physicians have this complicated workflow where they have to exit their EHR, open up a browser someplace. They got to know what they're looking for. They got to go look it up. Then they got to go back to the EHR. They got to pull out all the data that they want from a whole bunch of different views, plug that data into some online tool, run the calculation, get the score, put it back into the EHR, right? And you're going to do that. Sometimes you run up, 4 or 5 calculators per patient for a couple hundred patients. There's no way, right? They're not going to, but when they do it, the downside is you don't capture it. As a health system, you have no idea what level or adherence level your physicians have to those calculators, because you can't track it, right? And physicians don't like, they just get you to run some surveys, but nobody likes surveys, and physicians like them even less than most people. And so what's really cool about what we're doing is, because we're built into the EHR, we can actually track the application of evidence-based medicine across a population of in a health system, which means we can tell you how many times certain calculators were run. We can tell you the distribution of those scores. We can tell you if those scores are trending up or down, et cetera, and tie those to these outcomes that, if you can drive certain scores down, that correlates with certain outcomes that are bad, right? And if you drive those outcomes down or reduce the negative outcomes, right, you're talking about an improvement overall in your clinical care, which always equates to better outcomes for everybody, right? The physician, the
better
doctor,
outcomes, better clinical outcomes, better financial outcomes.
Exactly.
Right,
100%.
right.
Yeah. Jordon Ritchie, CEO of Aimedica, you have a big task ahead of you in the evidence-based medicine space, but we thank you for your time today and wish you and your team continued success.
Thank you. Really appreciate it. It's a pleasure to be on the show today.
Thank you.
Thanks for coming on.
On behalf of Matthew and the whole team here at Taking the Pulse, we hope you enjoyed today's conversation, likely learned a little something. I know that I did. And we look forward to seeing you next time right here on Taking the Pulse, a healthcare and life sciences podcast.